Hello, everyone. In our last season, we talked about advancing through complex pathologies of mitral valve disease and talking about restrictive pathology and how to manage cases such as rheumatic valve disease. In this season, we're going to be talking about something even more complex. What happens when patients are suffering infective acute bacterial endocarditis? As a result of endocarditis, there's usually tissue destruction of the leaflets themselves, and sometimes even creating an abscess of the annulus. What we're going to talk about in this season is different approaches to repair mitral valve endocarditis. In this first episode, we're going to be showing a technique we've called the bridging patch technique. Let's have a look. Acute bacterial endocarditis can be a difficult and challenging situation to manage surgically. Robotic approaches are feasible, and this is a young, emaciated woman who presents with acute bacterial endocarditis and a cerebral infarction due to a septic emboli, in whom a sternotomy would be suboptimal. As you can see, there is an annular abscess. And so the first step in any treatment of endocarditis is full and complete debridement of all infected material. We utilize this technique that we've called the bridging patch technique by harvesting autologous untreated pericardium to bridge the gap, particularly in lesions that impact the commissures. This is an onlay patch technique using interrupted fluoromonofilament sutures to create this repair of the defect. This is then followed after confirming competence with a annuloplasty band to create a competent valve without stenosis. Now for a second case, fairly similar, with a leaflet perforation associated with a commissural vegetation with a similar presentation. You can see there's quite an indurated and extreme vegetation associated with the perforation. The area is completely debrided, and note that spent time to make sure that the leading edge of the commissure as well as P3 is preserved, and we can use this to repair the defect since this area is supported. So an onlay patch is then constructed. Should you choose to utilize this technique, much like for anterior leaflet repairs, please make sure you harvest a large patch. Cannot be too large. And release of the anterior A3 cords and annuloplasty to confirm the repair without residual mitral regurgitation. So these patients are feasible to be repaired robotically. So now we've seen the bridging patch technique in a patient that required an A3-P3 reconstruction. Sometimes the vegetation occurs in different locations. A common location is the posterior leaflet, and join us in our next episode where we're going to talk about posterior leaflet vegetations and how we can approach that location.